Hi there, welcome to a presentation by CBH Education in our pharmacy revision series. Today we're going to be talking about tuberculosis, its treatment and key information to look out for in your clinical practice, and obviously when you're revising for things like OSCEs, exams and common cases that you will come across as well. So the first thing is tuberculosis is caused by the microbacterium tuberculosis. It's spread basically by respiratory droplets from an infected person. And obviously you've got two types of treatment. You've got the initial phase and then you've got the continuous phase. Initial phase involves 4 drugs: rifampicin, isoniazid, co-prescribed with pyridoxine hydrochloride, rifampicin and ethambutol. Then you continue for 4 months on rifampicin and isoniazid. Now, rifampicin is bactericidal and inhibits DNA-dependent RNA polymerase. Key side effects: nausea, thrombocytopenia, and vomiting. Enzyme inducer, something which is key. So you've got to look out for your drug interactions. You will be asked to look at drug interactions, which we'll cover in a later presentations. Core drug interactions with contraceptives, steroids, and warfarin. Key monitoring is LFTs, and obviously it discolors soft contact lenses. Patient and carers need to be told about the signs of liver disorder, so nausea, vomiting, malaise, jaundice, and obviously if patients do have abdominal pain, that warrants a referral into secondary care. So obviously if you've got somebody coming in with your pharmacy, you've done a medication use review, you've looked at the medication, that needs to be reviewed and obviously referred on. Now, isoniazid inhibits the biosynthesis of fatty acids of mycobacteria. Side effects: liver disease and peripheral neuropathy. Co-administration with pyridoxine. Key drug interactions with phenytoin and warfarin. Monitoring is with the LFTs. You've got to again counsel about hepatic disorders. So again, that nausea, malaise, jaundice, and obviously then abdominal pain. Another thing that comes into your OSCEs as well. You also have to counsel about the tyramine-rich foods, obviously avoiding things like mature cheeses, salami, pickled herring, bovril, oxo, marmite, similar meat or yeast extract, fermented soybean, beers, lagers or wines, histamine-rich foods such as very mature cheese, and certain fishes like tuna, mackerel, and salmon with isoniazid. This needs to be counselled, and it's also provided to the patient before they co-prescribe this as well. So they need to watch out for their diet. Again, something that will come into your OSCEs as well. So it's really worthwhile ensuring that you understand this fact as well. Now, ethambutol is bacteriostatic. The mechanism of action is not very well understood. Side effects are visual impairment, and obviously you get coloured vision. Drug interactions with isoniazid, obviously this is monitored. Patients do get regular blood tests as well. So obviously this one you have to look at the peak concentration as well. So these are the figures that have been quoted from the BNF. Another aspect is obviously you've got to do your LFT monitoring as well. Now, pyrozidamide is bactericidal in action. You've got your key side effects there. So what you'd look out for is appetite decreased. Gout is another one. So obviously you'd be looking at serum urates as well. If you're presented in an OSCE situation with raised serum urates, that'd be a matter of referral. Then hepatic disorders again. Okay, so it's really key that with all the 4 drugs, liver monitoring is done. Okay, and then again, like we've discussed with the other drugs, you've got to look out for the signs of hepatic disorders. Okay. Another thing is looking at the photosensitivity reaction as well. That's something that can come up as well. And obviously, these side effects are defined as being a range of side effects with regards to this drug as well. So obviously, just to reiterate, the frequency is not known of these side effects. It's really key that obviously if patients do get side effects, you actually counsel and drill down to the key side effects of what's going on. Is it a drug-related side effect? Can it be a drug interaction as well? One of the drug interactions is with allopurinol, and if you refer to the BNF, it's not a high-risk drug interaction. Now, some of the points you may come across in your revision in clinical practice is you've got to look at the age. So anyone who's aged under 65 and has been in prolonged contact. So obviously, if you're in a household, partner or person with pulmonary or laryngeal tuberculosis should be tested for latent tuberculosis. This is something that is very key, and it's stated in the BNF as well. Other issues you would come across is in immunocompromised patients, looking at the treatment options, what is there for them as well. And obviously from a history, you have to have a look. Are they, before obviously initiation of treatment or any issues, are they on disease modifying anti-rheumatoid arthritis drugs? Are they on Are they taking any other immunosuppressants? Have they had a transplant? It's linking your knowledge with these key things together, and something that would come up in your OSCEs as well, to recognizing things like cyclosporin, tacrolimus, looking at things, have they had a transplant before as well? Okay, now drug resistance is something that's really key, and one of the key themes that's going across CCG is something at a localized level as well. And obviously, hospitals have formularies. So that brings us on to obviously dispensing in specialist settings. So what happens here is this drug is actually prescribed within the hospital. It's generally not initiated in the community, because the thing is, the treatment needs to be monitored before patients are re-prescribed treatment. They have their blood tests. Also worth wondering as well, they have to have baseline renal tests before they're prescribed this drug as well, obviously to review the creatinine clearance if they have any form of renal impairment. Another thing that comes up as well is obviously if you're a healthcare worker, what treatment do you come up with there as well? And these obviously would come up in your OSCEs, and you can find the answers in the BNF for this as well. So obviously, when you're looking at things from a healthcare worker perspective, you've got to look, right, is it somebody new that's entered into the NHS? So they've got to have that testing for latent tuberculosis. Have the person had a BCG vaccine as well? Okay, then obviously if they test positive, they need to be offered the treatment as well. Okay, so the hospitals and obviously adjoining health organisations will have those healthcare policies in place as well. Health economics will come up in with tuberculosis as well, looking at the number of cases, for example, in an city compared to those that are residing in areas where of not high population density as well. Looking at the data, analysing the data, you may get presented with an OSCE situation on this as well, and how to do that calculation, and even how to evaluate the data. And one of your key skills as a pharmacist is evaluating that data and understanding, right, how can I put this into perspective, and obviously what things would you need to take into consideration as well. Now, we have mentioned about dispensing in specialist settings, but just to reiterate, patients do need to be presented into a hospital for that specific prescription in most cases. So if they come to the hospital pharmacy with a community hospital prescription or a hospital FP10, it has to be dispensed at that specific pharmacy. You can't refer them over to the GP, because one of the things is we have something called formularies. So obviously, if you do work in primary care, you'll understand the concept of formularies. If you're a pre-reg student, or you're going to be doing a GP placement around a GP practice or in primary care, it's really important that you understand the use of the formulary and what drugs are restricted. So different CCGs or clinical commissioning groups will have a RAG, so red, amber, green. They'll also have a color coding system in there as well. So it's really worth checking what is allowed to be prescribed, and obviously then how you refer the patient on as well. The reason why obviously it's not dispensed in these settings is we need to understand what monitoring is going on, and obviously the patients need to be in the specialist setting to get the relevant expertise and the right treatment as well. Thank you very much for listening to this presentation on tuberculosis, and for further videos on pharmacology, pharmacy revision, OTC drugs, OTC conditions, pharmaceutical calculations, and other areas of pharmacy to support you with your revision, please follow us on our Facebook, Instagram, and YouTube channels.